Hello, my name is Zenas Z. I'm a clinical senior lecturer based at the University of Manchester in the United Kingdom, and I'm a consultant dermatologist as well as an expert in pharmacoepidemiology. So to talk about this EADV conference, this has been a very grand scale conference so far, covering a lot of really important topics. What I would like to talk about first is some of our own research that we've presented at this conference. So one of my PhD students, John Teta, has presented his first work using Mendelian randomization to look at the risk of atopic dermatitis in association with lipid-lowering medications. And he's found that depending on your ancestry, you may get an increase or decrease in risk depending on the different lipid-lowering medications that you take. So he will proceed to also do a population-based study to try and triangulate this data. Another presentation we've contributed is through another PhD student of mine, Heber Bright. So just this morning, he's presented some data using the British Association of Dermatologists, Biologic and Immunomodulators Registry, or BADBIR. And in this particular study, what he did was to conduct a cohort study to look at the risk of serious infection associated with different medications. And what we found was that over time, the comparative difference in risk of serious infection could be different. So taking 5 years into account, what he found was most of the biologics and systemic treatments had very similar serious infection risks. So compared to adalimumab, for example, which is one of the most commonly used biologics. But there were some that were associated with higher risks that included the interleukin-17A inhibitors, secukinumab and ixekizumab, as well as apremilast. We then broke that down into different timeframes in 1, 2nd, 3rd, 4th, and 5th year, and found that it varied over this time. And it is very likely that some of these findings are associated with how we use these medications. So we may be selecting possibly people who have a higher risk of infection to go on something like apremilast, which is recognized to be a bit safer. And we need further research into this field. But some of this research also confirms what we know. So interleukin-23 inhibitors are a very safe option with a low risk of serious infection. Outside of our own research, I've also found some of the subspecialty sessions very interesting. One of the very important sessions that I attended was the EHSF session on HS. And some of the really important studies that have come through HS include some spatial transcriptomic data, where both two different sets of researchers have looked into different transcriptomics into HS and have found that particular drivers of abnormal epithelialization as well as the driving immunological factors also came up with the transcriptomics data. So for example, the importance of the Th17 pathways, but also plasma cells, B cells, and neutrophils in the driving of HS. Other important sessions from that particular morning included a study which was very interesting, which showed that the anti-inflammatory effect that was proven from antibiotics that is separate from the antimicrobial activity of these antibiotics. Finally, I'd just like to highlight a couple of late new breakers that have been very important space for HS. So the first interim analysis of the phase 3 randomized controlled trial for povorcitinib, which is a JAK1 inhibitor for use in HS, was presented in this particular meeting. And what they found was around a delta of 10 to 12% for the primary outcome of HiSCR 50, but there were also some uncertainties with regards to extrapolation to week 24, and it is likely that the maximum benefit of this drug is going to be seen from week 16 onwards. So we need to hopefully see the full phase 3 analysis for this particular drug, but it would be great to have a new small molecule option to add to the biologics options that we have in HS.